I wanted to cover some changes that occurred during the election last month, because they were very significant in terms of drug policy here in the United States anyway, and I wanted to acknowledge that before getting into this week's lecture. The other thing is that
Welcome to Rolling Stone News. I'm Elvis Metcalf. While the 2020 presidential results remained unclear the morning after Election Day, one thing for certain is that voters overwhelmingly approved a series of measures aimed at the war on drugs, including the legalization of marijuana in New Jersey, Arizona, and Montana, the decriminalization of psychedelic mushrooms in Washington, D.C., and the decriminalization of all drugs in Oregon. Voters in the state of Oregon also voted in favor of Measure 109, which allows for patients 21 and over to buy, possess, and consume psychedelic drugs at psilocybin service centers under the supervision of trained facilitators, while Measure 110, which decriminalized personal possession of all drugs including heroin, methamphetamine, LSD, and MDMA, also overwhelmingly passed with 60% of votes in favor. Measure 110 also called for the establishment of a drug addiction treatment program funded by its cannabis tax revenue. Cassandra Frederick, executive director of the Drug Policy Alliance that spearheaded the measure, said in a statement, quote, "Measure 110 is arguably the biggest blow to the war on drugs to date. It shifts the focus where it belongs, on people and public health, and removes one of the most common justifications for law enforcement to harass, arrest, prosecute, incarcerate, and deport people." On the marijuana legalization front, voters in New Jersey, Arizona, Montana, and South Dakota approved measures and initiatives to legalize adult-use marijuana, while Mississippi approved the establishment of the medical marijuana program. Thanks for watching. For more on this story and all your culture news, visit rollingstone.com.
So, welcome to it's actually module 14 and 15 combined. So, in that way, I guess we both kind of lucked out. I needed the extra time to put this lecture together, and you guys get a little extra time to work on things like other classes, or hopefully an extra credit paper for this class. But this week's lecture is on treatment, specifically medication-assisted treatment, but I figured I would take a crack at some of the issues regarding treatment that I think, they weren't that clear after I got done with this program before, and I'd like to try and clarify some of that for you before you move on in your training as alcohol and drug counselors. So we'll start with some introduction. We'll get into recovery capital, and we'll get into some results from some recent studies regarding how rapidly or how difficult it is in general for people to recover. And then we'll get into medication-assisted treatment for opioids, alcohol, nicotine, briefly for cocaine and gambling, and then some conclusions, and also try and include in your handout some additional information, because I have tons of information and I'm not going to test you on all of it, but I do want you to have it at your fingertips, because at some treatment facilities they actually use quite a few medications to help people during early recovery and detox, and you might want to be able to look up what those medicines are and what they're good for. So I'd like to start, since this is my one chance to take a crack at what treatment is, with some fundamentals of treatment. I would call them fundamental truths of treatment. And the first and probably most important fundamental, one that I didn't necessarily understand was as fundamental as it is, even being a physician, is you cannot give away what you do not have. And you can bang your head on that one for a long time. But basically, the idea is you must practice self-care. Almost invariably, you'll need therapy. You may need some medicine, and you should take it if you need it. And you are going to have to do something other than treating patients with the 12 steps or whatever type of recovery it is that you're helping people with to maintain your own recovery, because helping others as a job is not going to help to maintain your recovery. In fact, it's going to be a huge challenge to your recovery. So having a strong recovery yourself apart from your work is going to be inevitably a necessity if you want to remain in this field. So the second fundamental truth would be that people will forget what you say, but they will never forget how you made them feel. And I borrowed that from Maya Angelou, of course, but so that's why I think Carl Rogers' idea of unconditional positive regard for your client, and I would add for yourself, are imperative to good treatment, because you can explain all of the details about how each medication works, how their drug of choice worked, how all of the wonderful psychosocial modalities work, like CBT and motivation enhancement and all of these other things, and none of it's going to make any difference if you make the person feel terrible or can't help them to feel better, because they're going to forget all of those details. But if they got a respect and unconditional positive regard from you, they will never forget that. So the third fundamental truth would be that the provider-client relationship is the connection over which you can transmit any treatment. Basically an extension of the second truth, and that is that your experience, if you have any, with addiction, your background in recovery, if you have some, will certainly help to establish your credibility as somebody who can help a client with an addiction problem. But I would venture to say, or go out on a limb here and say, that if you don't have any knowledge of addiction treatment, your help is going to be limited. Your ability to help motivate that other person is going to be limited. You will certainly be able to develop some mutual respect based on your experience with addiction and recovery, but hopefully you can extend that respect by expressing through this relationship that you develop with your client effective methods to help them through their early recovery. So the next fundamental truth would be that a person is generally the sum of their 5 closest friends, and in that way, not only is that just a fact, but it shows why it's so important that if your friends use drugs and are not interested in recovery, that it's going to basically block your ability to grow or to recover, to change, I guess, or to recover. And the final fundamental truth would be that most clients enter treatment looking for change. They generally aren't at all sure what to change, how or when to change it. And that, I believe, is where either motivational interviewing or motivational enhancement therapy come in, because invariably clients want something to change when they come to treatment. But usually the thing that they're thinking needs to change is not their drug use, not their drinking, not, any of these necessarily recovery-oriented things. And a big part of our work in trying to help people recover is to help to establish how their drug or alcohol use has actually caused a lot of problems in their life, but you can't tell them that nearly as effectively as you can help them to figure out that that is what has happened. If it's their idea that drugs and alcohol are getting in the way of them having a life, then they will actually have significant motivation to try and recover. If you simply tell them that their drug use or their alcohol use is the problem, they're going to look at you like, what? Are you kidding me? Go bark at somebody else, don't bark at me. Alright, so when it comes to treatment, of course, addiction has traditionally not been treatable by any medical modality. There's been no real help in curing addiction or even curbing addiction from psychiatry, psychology, mental hospitals, or even correctional institutions. And the correlates of quitting, the things that generally occur that predict somebody quitting, are major life changes. Usually they're a positive life change, like getting married, having a baby, graduating from school or high school, college, something. Sometimes a negative change will force somebody to look in the mirror and want to do something different, like the overdose of a friend or surviving a major accident, especially if it was drug related. However, all of these are added stresses and can push a person to use more drugs instead of quit or want to quit. So when it comes to psychosocial treatments or medically assisted treatment, I think an important question to address is, what are we treating? Substance use disorder is use despite adverse consequences. So are we treating the substance use, or are we treating the adverse consequences? And if we're treating the substance dependence or use, that's where medication-assisted treatment comes in and can work wonders in detox, early withdrawal, and sometimes for harm reduction. With replacement therapy, medication-assisted treatment is wonderful. But when it comes to treating the rest of it, things like trauma, a sense of failure, a feeling of shame, regrets, a life driven by fear, a lack of support in recovery from friends or family, lack of effective coping mechanisms or skills, and a lack of personal self-care, that's where counselors really shine. That's where inpatient, intensive outpatient, and outpatient treatment can really help people. And often there's a team of people involved, counselors, social workers, nurses, potentially even doctors, in helping to get people through all of these issues. And the more of them that can be addressed in the period of treatment, or at least the problem beginning to be addressed in treatment, and thus giving people some hope that there's utility in continuing treatment after their discharge from their inpatient treatment, or after their discharge from their outpatient treatment, is invaluable. And medication-assisted treatment, of course, can help with people that have psychoses, hallucinations, or delusions, things like that. It can also help a little with anxiety and depression. Certainly, it can help people who are severely depressed or severely anxious, but often the medications for anxiety have their own addiction potential and can pose a problem. And then one of the huge problems in the field of addiction is, how do you measure success? And what do you consider success? How do you define success? And if you define success as getting a person into recovery, how do you define recovery? Most of the studies up until maybe the last 2 or 3 decades defined success, or at least the measurable part of success, as abstinence. The duration from either treatment or an attempt to quit without treatment until a person relapsed. Another measure that was a little bit more quantitative, a little less black and white, was, is there a difference in the intensity of drug use or alcohol use when they relapse? Are they using less? Are they using less often? And then another possible way of looking at it, or how many meetings are you attending? If you want to be kind of silly, you could say, how many phone numbers did you get in a meeting, and how many steps did you complete before you relapsed? But I don't think anybody really uses those as measures of success other than members of AA and NA. Usually early in recovery and people who don't understand what recovery really is. Which brings us to the next thing: what is recovery? And I guess traditionally it's been something that's been defined by each individual as they attempt to achieve recovery. But more recently, there have been more thorough and potentially academic, but also therapeutic attempts to define recovery. And also, how dimensional is recovery? Is there such a thing as being in recovery and not in recovery and that alone? Or are there degrees of recovery? And can one person have more recovery than another? Can there be different dimensions of recovery that you can measure? So, what is recovery has been a question that's plagued the addiction treatment community, because it has made research into what's effective very difficult. There have been many attempts to define recovery, and I guess the most, well, not the most recent, but one that was generally agreed on was that it's a complex phenomena that is very individual and that it occurs over time, and that was from a Betty Ford consensus group in 2007. Dennis, Scott, and Laudette in 2014 argued that it also takes around 5 years before recovery can be considered to be self-sustaining. So there's a period of time in which recovery is definitely more fragile than someone who's recovered for 5 years. And there are generally accepted fundamentals of recovery. One is abstinence, but that's about where it ends. Like, abstinence from what? Usually there's a consensus that it's abstinence from your drug of choice. A lot of people in AA or NA will say it's abstinence from all things that affect you from the neck up, but usually those all things are things like alcohol, heroin, cocaine, methamphetamine, marijuana, ecstasy, mushrooms, PCP, stuff like that. And in those groups, they encourage the use of caffeine by providing coffee at every meeting. They certainly permit the use of nicotine with regular breaks for smokers, and there's an unquestioning acceptance of the use of sugar. In fact, at several of the places that I worked, candy was an acceptable substitute for opioids, and most people going into the recovery home were either showed up with tons of candy or were given candy when they got there if they were trying to recover from opiates. Another fundamental of recovery is personal growth, but how do you define it, and what part or what type of growth is it? I would say that you're going to need emotional, spiritual community, a growth of recovery community, and you're going to also hopefully experience some significant physical recovery from your time when you're using or drinking. And then another fundamental would be an increasing sense of well-being for the individual in recovery. but that's not always true. Sometimes, having to face up to your character defects or things that you've done while you were using, or things that you did before using that drove you to use, or things that occurred in your life, like trauma, and having to face those things without chemicals can pose a significant challenge for a lot of people. But in general, there seems to be an increasing sense of satisfaction, serenity, peace, and joy amongst people that recover. And it's kind of like you can define it in the negative. If you're not experiencing an increasing sense of satisfaction, serenity, peace, and joy, you're most likely not in recovery. Now, what leads to those? Well, usually it's growth, emotional, spiritual, getting a community or a fellowship of people that are working on their own recovery that can help with those things, that leads to those things. So, to get a more functional definition of recovery, there's a growing consensus that recovery is a multifactorial, nonlinear process, with the Betty Ford group defining addiction recovery as voluntarily maintaining a lifestyle characterized by sobriety, personal health, and citizenship. And that's from their consensus group in 2007. Betty Ford definition also differentiates between early recovery, which is up to a year, sustained recovery between 1 year and 5 years, and what they considered stable recovery with more than 5 years. A similar definition was developed by the UK Drug Policy Commission, suggesting the possibility for non-abstinent recovery, which defines recovery as voluntarily sustained control over substance use, which maximizes health and well-being and participation in the rights, roles, and responsibilities of society. So they acknowledge that even abstinence isn't necessarily recovery, and that certainly even the people who define recovery as being sobriety and abstinence, it's still a matter of abstinence from what? So even with all of that, substance abuse still faces a tremendous number of challenges. So there's a significant awareness gap, I guess would be a politically correct way to put it, and roughly 84% of those who meet diagnostic criteria for some type of substance use disorder claim to have no problem. Some people state that this is simply denial. Other people, I think, acknowledge that for those people, substance use is a solution, even though it's causing a lot of other problems. There's a motivational gap, for sure, and that is that even though people recognize that their addiction may be causing a problem, roughly a third of them won't seek treatment. There's an availability gap. Only 50% of people are able to get addiction treatment on demand. There's certainly a continuity gap in that only 25% who enter treatment will complete with a positive discharge, and there's an outcome gap in that at least 50% will not remain abstinent for the following year after treatment. And of course, as I've covered before, mind-blowingly 85% of addicts recover on their own. I know, you guys don't believe me, but hey, it's actually true. It's based in fact. And because it's been something that's difficult for people to accept in this field, I think it was important that we look at how many attempts it takes for people to quit. And thanks to a study by William White and colleagues in 2019, published in May, we have a good idea of how many times it takes people to quit. So the study used a national sample. They looked at roughly 40,000 people They selected 2,002 of them as people who had recovered from a significant alcohol or other drug problem at random. The study looked to estimate the average number of recovery attempts and the variability in attempts prior to resolution of an alcohol or other drug problem. They explored the demographic and clinical predictors of the number of recovery attempts needed prior to successful entry into recovery. And they also characterized the relationship between the number of recovery attempts and indices of quality of life, psychological well-being, and other things after the alcohol or the drug problem resolved. So this is what they found. When represented as a histogram, most people, the vast majority, required less than 20 attempts. Most of them between 1 and 3 attempts, roughly. But there certainly were outliers that required even more than 100 attempts. So when you truncate this to people who required up to 10 or more attempts, this is the distribution you get. You get a significant number of people that didn't even make an attempt, they just stopped. You get the majority of people requiring 1 attempt. You get a significant number of people requiring 2 and 3 attempts, and then a small diminishing number as you increase the number of attempts up to 9, basically. And I guess a bit of a bump there at 5, huh? And then for more than 10, there were quite a few people. Now, how they looked at this was, if you required more than 10, they considered you to be an outlier because, well, statistically speaking, that's exactly what you are. And here's the histogram of the full range, I mean not the histogram, the forest plot of the full range of number of recovery attempts. And then here's when you exclude the outliers, statistically speaking. So the majority of people required a median of 2 attempts. And the 50% of people who were in recovery, so 50% of the sample, required between 1 and 4 attempts, with most people requiring 2. So they looked at what leads people to need fewer attempts, and being white, unfortunately, was one of the things. White people generally required 2, African Americans or blacks 3, being not married required more attempts than being married or living with a partner, between 1 and 5 to represent 50% of the non-married, and between 1 and 4 to represent those that were married. Other things that correlated with recovery were if you were depressed, it generally took you an additional attempt to recover. If you had anxiety, same thing, an additional attempt. If you only received outpatient treatment, it took an additional attempt. If you received inpatient treatment, it actually added 2 attempts. So in general, this isn't a causal thing. This is simply people who enter inpatient and outpatient treatment require more help recovering, and they're going to make more attempts to recover than people that don't end up in treatment. For people who did not attend mutual assistance groups like AA or NA, they took between 1 and 3 attempts to recover. If you were a former attendee of one of those groups, it was on average 2 attempts, but between 1 and 5. And if you had attended a meeting in the past 3 months, generally it took you 4 attempts to quit, to recover. So receiving any treatment or recovery services generally meant you needed at least 3 attempts to quit. And once again, I would not consider this to be a causal thing. This is simply that people who receive services are usually the ones who have already attempted 2 or 3 times to quit, and they end up going to treatment or receiving some kind of recovery services in an attempt to quit because they figure they can't quit on their own. So here's the kicker. How many recovery attempts does it take to successfully resolve an alcohol or drug problem? From the National Recovery or National Study of Recovery for alcohol, on average, it's 2. Cannabis, the same, 2. For opioids, 3. Stimulants, 2. And other drugs, the range is from 1 to 6 attempts. So generally, at 2 attempts, people don't seek treatment. So among those that end up seeking treatment, this is what Samsha would have to say. Opioid addicts have an 80% relapse rate on abstinence-only treatment, whether that's inpatient, outpatient, ER, medical office-based, or Narcotics Anonymous. Alcohol addicts have a 70% relapse rate. Stimulant addicts have a 60% relapse rate. And tobacco users have a cold turkey success rate of less than 5%. Added sugar has only a handful of people who have successfully stopped partaking of any added sugar, and most people don't even try to stop caffeine. So here's the standard outlook from a 1971 study looking at people relapse rates over time for heroin users, cigarette and alcohol users, and this is relapse after treatment. You can see within 2 weeks a good 40% almost of alcoholics have already relapsed. And they didn't sample heroin and smoking, but they're similar. You know, they've got some, I think for smoking it's like almost 50% have relapsed within 2 weeks. So that one would come right down here and then head on out. Yeah, so pretty bad. And alcohol, pretty dismal. If you look at 1-year recovery rates, they're on the order of 25 or maybe 12-15% for heroin or smoking. So treatment is definitely for the difficult cases, and treatment should be tailored to those that end up seeking treatment. Generally, there are people that started younger, they've used longer, they use multiple substances, they can turn almost any pleasure into an addiction, they've been through treatment several times, they often have significant childhood adversity, or ACEs, they have multiple psychiatric diagnoses, they have a very low sense of self-efficacy, they cannot help themselves. They have a strong sense of learned helplessness. They usually are from a lower education family and have not achieved much education success themselves, and their family and peer group are often also addicts. And often whatever trauma they missed out on as a child, they've certainly made up for in the correctional system. They have significant shame over their trauma, their drug use, and their feeling of helplessness, and they have shame over being a failure with a lack of career, lack of family involvement. Mothers have tremendous shame over losing or having given up their children, and fathers have shame over giving up wives and kids. And they also have shame over not having home or being homeless.
Most people think of opioids when they think of overdose, but even now, even in the fentanyl era, polysubstance use is really the rule. So opioids are often involved, but usually there's at least one other substance involved. There are patients who we see who, not just struggle with addiction, but also with poverty and homelessness and trauma histories. And so their use of substances both perpetuates the trauma, but it also helps them cope with it, right? So then if we initiate them in treatment, they go through their day more clear-headed, and that's not always so easy to cope with. And so they may reach for other substances to help, cope with that. Polysubstance use particularly frustrating because we have medications and treatments that work for opioid use disorder, but for some of the other substances that people use, we don't have the same effective medication treatments. We need more than one skill set. It really takes a team to kind of try to meet their needs.
When most people hear about overdose, they think of opioids, heroin, fentanyl, or prescription pain medications. But most overdose deaths also involve other substances as well. Therefore, these overdoses are actually due to polysubstance use. When it comes to overdose, polysubstance use is the rule. Someone overdosing on one substance alone is the exception. So why do people use multiple substances? People use substances to feel good, meaning to get high or feel euphoria, to feel normal, meaning to make up for the chemicals their brain is lacking due to repeated drug use, or to feel better, meaning the person is trying to relieve underlying physical or psychological pain or discomfort. Unfortunately, all drugs have side effects, undesirable aspects that come with the effect people are trying to achieve. Opioids can cause drowsiness and constipation. Stimulants like cocaine and methamphetamine can cause anxiety, irritability, and difficulty sleeping. It is normal and should be expected that people who use drugs will reach for other substances to relieve the side effects they are experiencing. Many people who binge on stimulants use sedating substances like alcohol, benzodiazepines, or opioids to come down from the stimulant high. For people who use opioids, alcohol, or benzodiazepines on a daily basis, withdrawal symptoms are key drivers of ongoing daily use of the primary substance. Opioid withdrawal symptoms include irritability, anxiety, runny nose and eyes, sweating, nausea, diarrhea, full body muscle aches. People describe withdrawing from opioids as the worst flu of their life. Seeking relief from these withdrawal symptoms is a powerful driver, stronger than any cravings for euphoria. People who use daily develop increasing tolerance to the primary substance and struggle more and more to control and tolerate withdrawal symptoms. To cope with withdrawal symptoms, people commonly take other substances that extend or mimic the effects of the primary substances. For people who use opioids, these include other sedating medications like benzodiazepines, alcohol, anticholinergics, clonidine, and gabapentin. People may also use synergistic substances to boost the euphoria or the withdrawal relief of the primary drug. People who use opioids commonly boost the effects with a benzodiazepine. People who use cocaine often drink alcohol at the same time, not only as landing gear, but also to intensify and prolong their cocaine high. The combination of opioids with other sedatives, like benzodiazepines, and the combination of cocaine and alcohol results in increased risk of toxicity, specifically increased risk of overdose. Polysubstance use is not only the rule among people who overdose, but it is very common among people in general who use substances. The most common substance that is used with other substances is nicotine. In addition to immediate health risks like overdose, people who use substances are at high risk of long-term complications from smoking, like cancer, heart disease, and stroke. People who use multiple substances are less likely to initiate and engage in treatment. Those who are able to reduce their polysubstance use are more likely to be successful in treatment. The best way to understand and help a person with polysubstance use is to ask them about their substance use. Ask why they use each substance and how their use of each substance is related. Understanding the role of polysubstance use can help guide medication and behavioral treatment. It is crucial that we try to lower barriers to treatment for this population and ensure access to harm reduction services. In summary, healthcare providers should 1. Recognize that polysubstance use is the rule rather than the exception. 2. People use multiple substances to minimize side effects and withdrawal symptoms, as well as to boost effects of primary substance. 3. Take detailed histories that include asking patients why they use each substance and how their use of each substance is related. 4. Ask about tobacco and nicotine use and recognize them as form of polysubstance use. 5. Provide low barrier and harm reduction services to engage and improve the safety of people who use multiple substances.
So, what are some determinants of health? Well, a lot of people in the social sciences have looked at this, and there are interpersonal or intrapersonal, interpersonal, institutional, community, and public policy factors that enter into determinants of health. But the one I want to cover is recovery capital. Robert Granfield and William Cloud introduced and elaborated the concept of recovery capital in a series of articles that they wrote or authored, and also in a 1999 book called Coming Clean: Overcoming Addiction Without Treatment. They define recovery capital as the volume of internal and external assets that can be brought to bear to initiate and sustain recovery for alcoholics or other drug addicts, drug users, people with a drug problem. Recovery capital or recovery capacity differs from individual to individual, differs within the same individual at multiple points in time. Recovery capital also interacts with problem severity to shape the intensity and duration of the support needed to achieve recovery. This interaction dictates the intensity or level of care one needs in terms of professional treatment and the intensity and duration of post-treatment recovery support services. So, there's a recovery capital index that looks at personal recovery capital, family and social recovery capital, and cultural recovery capital. And how does an individual's physical and human capital help initiate or sustain recovery through physical well-being, mental well-being, spiritual well-being, and self-determination? And the family and social recovery capital are family relationships, social relationships, relationships to recovery supports. And cultural recovery capital are social values, social beliefs, and relationship to culturally relevant recovery supports. Another person put a constellation of things together that all influence recovery capital. So, human capital and financial capital, social capital, and community capital, with all of these determinants, interact to add up to recovery capital. And here, although I'm not going to cover it during the lecture, are some examples of people with either low or positive human capital, financial capital, social capital, and community capital. So what is the impact of recovery capital? Well, I would say the biggest impact has been that it has made recovery more measurable. So research has been able to document recovery with better consistency, validity, and accuracy. So increases in recovery capital can spark turning points that end addiction careers, trigger recovery initiation, elevate coping abilities, and enhance quality of life in long-term recovery. And that's been shown in several studies. Such turning points, both at climactic transformations and incremental change processes, may require the accumulation of elements of recovery capital of varying importance within particular stages of long-term recovery. Recovery capital is not equally distributed across individuals or social groups. Members of historically disempowered groups often seeking recovery from addiction lack assets that are taken for granted by those seeking recovery from positions of privilege. Further, post-treatment recovery checkups and, when needed, early reintervention can help preserve the recovery capital developed through addiction treatment. So assessing recovery capital before initiating treatment, after treatment, and during post-recovery checkups, which a lot of people don't get but should, can be very beneficial in helping to identify what people have as strengths and what are barriers to their continued recovery or their increased recovery. Most clients with severely depleted family or community recovery capital gain little from individual focused addiction treatment that fails to mobilize family and community resources. Man, is that ever true? And you may run into that problem in the treatment facility where you end up working as an intern, that you'll see people that don't have family or community recovery capital with 10, even 12 times having gone through treatment, if they're lucky enough to have the financial capability or good insurance, something like that, that allows them to continue attempting to recover. But without that family or community resources actually being something that are interested in utilizing and being something that's available, they will just continue to fail. Long-term recovery outcomes for those with the most severe alcohol and drug problems may have more to do with family and community recovery capital than attributes of the individual or a particular treatment protocol. And there are several methods of assessing recovery capital. Hopefully, all of the places where you go as an intern will utilize at least one of these methods of assessing recovery capital. The initial one, probably the best known, is the assessment of recovery capital, which is a scale developed in 2013. There's also a life in recovery scale developed that same year, and then one that was just published, which is the Strengths and Barriers Recovery Scale, published this year. And it is specifically oriented towards treatment, trying to help people to identify their strengths and what barriers they will have in terms of recovery, based on the principles of what represents recovery capital. So from this same National Recovery Survey, it was determined that roughly 1 in 10 Americans have resolved an alcohol or other drug problem. Primary substance that they have or had the problem with was alcohol. Others include cannabis, cocaine, meth, and opiates or opioids, and the sample demographics are given here. And the distribution of the number of years in recovery is basically reverse exponential, with people having 0 to I believe that's 2 2 to 4, and as you increase the number of years in recovery, the number of people drops. They identified a number of different pathways to recovery. About half of them utilized some kind of assistance in recovery, half of them did not. So this sample isn't necessarily representative of the population in general, but these were people with significant recovery potentially. And about half of them were completely abstinent from alcohol and all other drugs as they saw them to be drugs. 73% were abstinent from alcohol and other drugs that they had identified as problematic, and nearly half of them self-identified as being in recovery, with the other half not identifying. And 30% had received some type of formal treatment, 17% an outpatient treatment, 9% had participated in medication-assisted treatment. About a fifth of them, a little less, had some kind of recovery support services, and about half of them participated in some self-help group, with a little over a third of them being in AA. So they looked at recovery indices with years in recovery, including quality of life, happiness, recovery capital, psychological distress, and self-esteem, and they found the general trend for people in recovery, as you increase the number of years in recovery, quality of life, happiness, capital, and self-esteem all increase, and psychological distress decreases. And if we left it here, it would be a wonderful story about how as soon as you enter recovery, everything's great. But this was using a very broad brush to look at the scatter plot of these indices. As you look with more detail, you can see that within the first 5 years of recovery, the decrease in distress is relatively consistent, and the increase in well-being, whether it's self-esteem, happiness, or quality of life, takes off more after, much more. It increases the whole time, but it really takes off after 2 years in recovery. And the capital in recovery initially goes up and then somewhat down during the second year, which would be a marker that this second year is definitely something that's a time to watch out. And actually, when you look at it on a 0 to 2 year scale, they identified that during the first roughly 3/4 of a year of recovery, psychological distress is increased, and quality of life, self-esteem, and happiness decrease. And it's only after about a year and a quarter roughly that these things start to head in the right direction. So right in here, I guess, is where people are starting to do their 8th and 9th step, and this is probably their 4th step right here, 4th and 5th. I'm guessing, I don't know, but that's what it looks like. Because getting through trying to address all of the baggage, all of the character defects, all of the problems is something that generally tears people down, and they rely on the fellowship that they're in, of new friends, AA, NA, whatever it might be, in friends in recovery, that is, of course, to get them through the problems of the initial recovery process. It's not always a picnic. In fact, if it's going to be effective, it usually isn't a picnic. So, they looked at different races and how quality of life, happiness, and psychological distress were broken down in the first 5 years of recovery. And in general, for white non-Hispanics, Hispanics, and black non-Hispanics, quality of life increased during the first 5 years. Happiness increased during the first 5 years, and psychological distress decreased during the first 5 years. Other non-Hispanic, generally for some reason, quality of life, happiness went down, and psychological distress went up in recovery. And that may be some of the reason why Native Americans have such difficulty with recovery. So, when it comes to assessing or evaluating the success of medically assisted treatment, most treatments, whether psychosocial or medication assisted, have not been assessed in terms of recovery capital, and treatments are currently being assessed by mostly period of abstinence following treatment, or sometimes the level of use after treatment and before treatment. And medically assisted treatment is almost always listed in terms of abstinence or survival. Most addiction treatment centers currently claim a 90 to 95% success rate, although there's no systematic evidence to support that claim. There's no financial incentive for the treatment center to try and study that to find out what the truth is and reveal that, because anybody claiming less than 90 to 95% would be the outlier, and often it's not even clear what they mean by success. So most of what we're going to be discussing is medically assisted treatment in terms of abstinence, but also a little bit about survival. So it's important to know what the effect is in terms of statistics when it comes to describing how effective any of these interventions is. So I know it's a little above and beyond the scope of this class, but I'd like to try and introduce the concept of Cohen's d as the difference between means and then scaled by the standard deviation, which gives a relatively consistent number when you have two standardly or similarly distributed populations, both the treatment and the control. So generally speaking, for this measure, a value of 0.2 or less is considered negligible. A value of 0.2 to 0.5 is small, 0.5 to 0.8 is medium, and anything larger than 0.8 is considered large. And in fact, by the time you get up to 3, there's no overlap between the treatment population and the control, which is extreme. So this is the idea anyway. You start off with two populations that are assumed to be identical in that blue would be overlapping the green. And then you apply some treatment, whether it's teaching, like an educational treatment, brief intervention, give them some type of medication, whatever it might be. And then you look using this parameter at the distance between the two means, scaled by the standard deviation. And that gives you some idea as to how effective that treatment was compared to the controls. So this is some idea here. Here's 0.5, effect size of 1, effect size of 2, and an effect size of 3. So when it comes to small effects, it's difficult to see with the naked eye what the difference is between them. For example, Cohen reports that a height difference between 15-year-old and 16-year-old girls in the U.S. population is about this, a small effect size, less than or about 0.2. So if you took a group of 10 15-year-olds and a group of 10 16-year-olds and had them stand next to each other, and you looked at the two groups, you'd have a hard time telling that there's a difference in height. You'd only be able to get to see that difference if you sampled a large enough group of girls and then actually carefully measured their height and then took the average of that. For a medium effect size, it's probably big enough to discern with the naked eye, at least in the case of looking at height. And he gives the example of the difference in height between 13 and 18-year-old girls, and that is about a 0.8, which is a large effect. And it's grossly perceptible and therefore large. And for the most part, effects under 0.2 are considered trivial, and even if they're statistically significant, they're often not important. So, of course, any effect is has to be taken in terms of the context. So sometimes large effects aren't necessarily useful in clinical practice, and sometimes small effects make a huge difference. Another idea here is the funnel plot, and that is simply to say that if you take a very small sample of people, like 3, and ask them how many times it took each of them to, how many attempts it took to recover, you'll find that as you take 3 people and mark it, the average of those 3 might be 1, it might be 30, it might be 15, it might be 5, but it varies a lot when you're only taking a small sample. As you increase the sample size, and say instead of taking 3 people, you took 30 people, you'd be getting a points up here that are closer to the actual value. And then as you continue to increase size, to maybe 3,000 people, you might get points in here. And then if you go to 30,000 or even 300,000, you might get points that are in here. And eventually you'd find, this value of 4. If you took maybe the whole population, 300 million people, you'd be like, oh, it's 4. And that's called a funnel plot. And normally on these are used to determine or to demonstrate basically what happens when you're studying something. So we're going to find that a number of the medications that are used for medically assisted treatment haven't been studied very well, and the number of people in the samples is very small, and thus the certainty about how effective those medications is very uncertain. We don't really know how effective they are. They look effective, but with very small samples, it can vary widely as to how effective it is. And as you increase sample size, you can become more confident about how effective or ineffective a medication is. And that's what this funnel is. So, especially when it comes to alcohol, there's only a couple of treatments that actually have been well studied enough to be able to be fairly certain about the effect size. Alright, so when it comes to psychosocial interventions, there was a study published, I think, 3 or 4 years ago that did a meta-analysis of various interventions like contingency management, cognitive behavioral therapy with contingency management, CBT alone, and relapse prevention, and they looked at the effect size. And they found for CBT alone and relapse prevention, and I put a line here at 0.2, which is a small or possibly negligible effect size, that they found, given that this bar goes across the 0.2, they didn't have enough sample size in the collected 13 studies that were using CBT to be able to show that it was any different than negligible. If they had something where they had a bar like this around this mean value, then you could say that it's statistically significant, significantly different than negligible. But for both of these, they were basically negligible effect. For contingency management, it showed a modest effect, which is about 0.6, and it was statistically significantly different than a negligible effect, which is great. For CBT with contingency management, it looked wonderful. A large effect, a little bit more than 1, but there weren't enough studies with enough participants to be able to say that that's the actual, with any certainty, to be able to say that that's the actual effect. In fact, this bar is so broad, it goes all the way down to a harmful effect, which is less than 0. It might actually be encouraging people to continue in their addiction instead of having a large effect on improving their addiction. And they study these psychosocial interventions in terms of multiple different substances. For polysubstance abuse or polysubstance users, there certainly was no statistically significant effect by any of these types of treatment. For cocaine users, it was almost statistically significant and a modest effect at a little over 0.6. For opiate users, it was a very modest effect at about 0.4, and once again, not statistically significant. And the only one that achieved statistical significance in these 24 or so studies was cannabis, and that was in 5 studies. It had a borderline large effect that was just barely statistically better than negligible. So, in total, psychosocial interventions don't necessarily have a great effect on addicts of these types of substances anyway.
Thank you for watching this brief webinar on medication-assisted treatment for alcohol and opiate use disorders, presented by SBIRT Colorado. The Substance Abuse and Mental Health Services Administration, or SAMHSA, defines medication-assisted treatment as combining behavioral therapy and medications to treat substance use disorders. Identification begins with screening to determine risk associated with alcohol, opiate, or other drug use. Screening, brief intervention, and referral to treatment, or SBIRT, is a recommended universal prevention service. Find out more about SBIRT training and technical assistance in Colorado at improvinghealthcolorado.org. Refer to the DSM-5 for more information on the diagnosis of alcohol, opiate, or other drug use disorders. Substance use disorders are classified as mild, moderate, or severe. The Prescription Drug Monitoring Program is an important tool to identify possible unreported use of opiates. For more information on assessing a patient for the need for medication-assisted treatment, visit samhsa.gov. After an assessment, it is sometimes determined that medication-assisted treatment is indicated. Under federal law, medication-assisted treatment patients must receive counseling, which could include different forms of behavioral therapy. Medication-assisted treatment service professionals are required to acquire and maintain certifications to legally dispense and prescribe opioid dependency treatments. SAMHSA's Division of Pharmacological Therapies makes available opioid prescribing courses, webinars, workshops and summits, and publications and research for physicians. More information on becoming certified can be found at samhsa.gov. Little is known about the factors that physicians consider when deciding whether to prescribe medication-assisted treatment to their patients, but some barriers have been identified. Awareness and comfort using medication-assisted treatment among primary care clinicians can sometimes be a barrier, as well as patient awareness and likelihood of bringing up medications as an approach to treatment. Research is needed regarding the preferences of patients, but there is little reason to assume readiness for public acceptance of medication-assisted treatment, except for the possibility of positive attitudes generated from knowing individuals who have benefited from methadone treatment. Understanding of insurance coverage is another big barrier. SAMHSA put out a publication called Medicaid Coverage and Financing of Medications to Treat Alcohol and Opioid Use Disorders that can help physicians understand how medication-assisted treatment is covered by insurances. For more information or for a free digital copy, visit samhsa.gov. Another identified barrier comes from a 2009 survey of State Department of Corrections leaders, which found that medications were generally not a highly prioritized treatment service for these purchasers of treatment services. More data are needed to develop an in-depth understanding of the reasons behind the limited adoption and implementation of medications for individuals involved within the criminal justice system.
There's been a high prevalence of alcohol use disorder in the U.S., even if it's been increasing recently. In fact, the prevalence of alcohol use disorder looks like it's gone up by about 50% in the last 10 years. And just like with other substance use disorders, most people with alcohol use disorders get no treatment. And of those who do get treatment, very few get pharmacotherapy or get medications to treat their alcohol use disorder. So it's low-hanging fruit. We ought to be treating people with this disorder. We have medications that work, that help people. I had a patient recently who had a complication of taking a medication for alcohol use disorder. And he came back and he wanted another injection. And I said to him, well, you know, you had this complication, maybe we should try something else. Or he said, no, that was really working for me. I'd like to take it even though I know I might get that again. And despite that, he wanted the help of this medication. So he really felt like it helped him not drink. And that was important to him.
Alcohol use disorder is very common. In fact, it is more common than all other substance use disorders combined. Alcohol use disorder is often a chronic medical condition and is potentially fatal. Almost 10% of all deaths in the U.S. are related to alcohol, making it the third leading cause of preventable death in the United States. Of those classified as needing treatment for their alcohol use, including people diagnosed in a medical setting, only 8.9% received treatment at a specialty addiction facility in 2018. There are medications for treatment of alcohol use disorder that are not being prescribed. There are a number of reasons for this. Many addiction treatment programs do not have the capacity or capability to treat alcohol use disorder with medication. Additionally, some patients and clinicians do not believe that medication for alcohol use is helpful. Another reason is the myth that taking medication is just trading one addiction for another, and this, unfortunately, may discourage people from ever trying a medication for alcohol use disorder. Only 10% of people with a diagnosed alcohol use disorder are receiving medication. Of that 10%, typically only one prescription is received per person each year. There is no magic bullet for the treatment of alcohol use disorder. It is true that available medications for alcohol use disorder have modest efficacy. Even though this is the case, medical providers should offer medications that are known to have any efficacy to patients with alcohol use disorder. Who should be offered medication? People with alcohol use disorder including 1. Anyone experiencing alcohol cravings. 2. Anyone who is currently drinking heavy amounts of alcohol. 3. Anyone who is thought to be at risk for returning to heavy drinking. What medications can be prescribed for the treatment of alcohol use disorder? There are 3 FDA-approved medications for the treatment of alcohol use disorder: naltrexone, acamprosate, and disulfiram. There are 2 additional medications that are not FDA-approved for the treatment of alcohol use disorder, but have shown some efficacy in treatment: topiramate and gabapentin. Naltrexone is typically considered a first-line treatment for alcohol use disorder. Naltrexone can be given as either a daily pill or as a monthly injection. Naltrexone is an opioid antagonist that is used to treat opioid use disorder. For this reason, it cannot be given to people who are taking opioids because it will precipitate withdrawal and prevent opioid effects. Why would the same medication work for alcohol use disorder? Drinking feels pleasurable in part because it increases endogenous opioids in the brain's reward pathway, and naltrexone, an opioid antagonist, blocks that pathway. Naltrexone does not block the effects of alcohol, but rather dulls the body's response. There are numerous other pathways through which alcohol affects the brain's reward system. However, naltrexone is unable to treat all of alcohol's effects. Naltrexone should not be given to people with acute hepatitis or liver failure, but it can be given to people with chronic hepatitis and modest elevations of liver enzymes, ALT, AST. The main side effects of naltrexone are nausea and dizziness. Naltrexone, in the tablet formulation, can be prescribed as needed to individuals who may benefit from taking it in anticipation of situations where they may be triggered to drink alcohol. Another medication on the FDA-approved list for alcohol use disorder is acamprosate. It is typically dosed at 2 tablets 3 times a day. Acamprosate affects different neurotransmitter systems than naltrexone, including glutamate and GABA, but we don't know exactly how it works. Acamprosate seems to have an effect on protracted withdrawal symptoms, and thus may work by suppressing persistent symptoms of withdrawal. Acamprosate is typically more effective in those people who are not currently drinking. Acamprosate cannot be given to people with kidney failure. The main side effect is diarrhea, which tends to resolve. The third medication FDA approved for alcohol use disorder is disulfiram. It has been in use for more than 60 years. The typical disulfiram dose is 1 tablet per day. If a person taking disulfiram combines it with alcohol, it can lead to accumulation of a byproduct that can make that person feel very sick. The disulfiram alcohol reaction can cause flushing, sweating, and nausea. Often, people choose not to drink while taking disulfiram to avoid these side effects. Disulfiram can be harmful to the liver, therefore liver enzymes should be monitored. People who are cognitively impaired should not take disulfiram, nor should people who have severe heart disease. The side effects of disulfiram include drowsiness, metallic taste, and many medication interactions. The effectiveness of topiramate is similar to FDA-approved medications for alcohol use disorder, although it has more side effects. Topiramate works on the GABA and glutamate systems similar to acamprosate. Topiramate doses need to be titrated up and then can be taken once or twice a day. Contraindications include kidney or liver disease, glaucoma, and anorexia. The main side effects for topiramate are paresthesia, lack of appetite, weight loss, cognitive dysfunction, somnolence, and altered taste. As for gabapentin, the results of clinical trials have been mixed, but a more recent trial found no benefit for alcohol use disorder. In addition to those medications already mentioned, medication treatment for mood disorders in people with alcohol use disorders may have positive effects on alcohol use. In summary, 1. Alcohol use disorder should be treated with all known efficacious treatments, including medications. 2. Naltrexone is a first-line treatment for alcohol use disorder unless a patient is on opioids. 3. Great attention should be paid to supporting adherence by frequent patient contact or engaging the patient's support system.
So let's take a look at medically assisted instead of psychosocial treatments. The one treatment for alcohol that has been studied with enough participants to be able to say with fair certainty is acamprosate, and it has at best a very small effect, 0.15, and it was the only intervention with a big enough evidence of benefit for maintained alcohol abstinence and acceptability up to 12 months after detox in primary care setting. The quality of the evidence for most treatments was low or very low, and most evidence was derived from a single small trial regarding the use of other medications for the treatment of alcohol. And more evidence from high-quality randomized controlled trials is therefore needed on the best interventions in primary care to inform clinical treatment and enable patient access. And the problem with that is that most drug companies aren't interested in doing these trials because these medications are no longer patented. So this is a network plot from a study in the British Medical Journal this year regarding alcohol abstinence in relation to treatment for alcohol dependence. And the size of these circles is the number of patient hours that each one of these circles has been studied. So placebo, of course, is the best studied because all of these other medications have been studied in relationship to placebo. The psychosocial treatments are down here, like treatment as usual, CBT, MET, short form CBT, and these have been studied in reference to treatment as usual, each one of these other types of psychosocial treatments. And then there have been a couple of medications that have been studied in comparison to naltrexone, and a couple of treatments that have been studied in comparison to acamprosate. But clearly the best studied relationship is between placebo and acamprosate. And as I already showed, acamprosate has a small effect size. So it doesn't look like it's very effective, and that's most likely why when it comes to treating alcoholism, most medications aren't even utilized. And here is a clustered ranking plot where the medication or treatment's ability to increase abstinence increases in this direction on the x-axis, and patients' ability to continue in treatment because the treatment's tolerable increases as you go down the y-axis. So something right here would be fairly ideal. Of course, there are no treatments like that. Acamprosate is right here with a very small effect size. Placebo is here with, of course, assumed no effect. And then medicines or treatments that look like they may be better are acamprosate with naltrexone. Looks like it may be significantly better at increasing abstinence and better tolerated than acamprosate all by itself. But so far, the evidence that this is actually how effective this combination is low to moderate. Another one that looks promising is acamprosate and a nursing visit. Once again, very well tolerated and definitely better than acamprosate alone in terms of increasing abstinence. Some of the ones that are a little bit less well tolerated but better at increasing abstinence are naltrexone with GHB, quetiapine or naltrexone, GHB, and escitalopram, which is an antidepressant. So that combination looks like it's very effective at maintaining or increasing abstinence, but not very good at being tolerable. And the evidence so far is low and very low for how confident we are this is where it belongs on this graph. The other medicine that was tried, that has been tried sufficiently to be able to say with some certainty where it belongs on here in terms of its ability to be tolerated and its ability to increase abstinence, is this tiopride, and it is not that well tolerated, and it is worse than placebo at increasing abstinence. So, not effective. And here's some relative risk numbers for the efficacy of these various treatments versus placebo, GHB is relatively effective at reducing the likelihood of people returning to drinking or returning to heavy drinking, but it's not known yet how it relates to heavy drinking days, and it has relatively few side effects, but also there are no long-term trials, and the amount of evidence favoring GHB is relatively small. So each one of these treatments you can see here, like acomprozate, does a very modest job. You're about 15% less likely to drink, and you're maybe 1% less likely to go back to heavy drinking. Fortunately, it also has relatively mild side effects, but still it doesn't matter because it's not very effective at reducing people's drinking. And the same for the naltrexone oral. All by itself, it's maybe 4% reduction in return to drinking, and maybe a 17% reduction in return to heavy drinking. So all by itself, it's not a great treatment. And the injection looks like it's less effective at keeping people from returning to heavy drinking even than the oral. The advantage, of course, with the injection of naltrexone is that it's a 1 month treatment at a time, so every day you don't have to take the naltrexone tablet to maintain your decision to remain abstinent. You get the shot once a month, so it reduces people's non-compliance, or it hugely increases compliance with the medication, at least.
So Dr. Williams, I was kind of hoping that maybe we could start by talking a little bit about MAT medications. We've heard a lot about MAT in the news, and people are talking about it, but I don't know if everyone's really familiar with what MAT stands for and kind of what it means when it comes to treatment.
I think there has been more and more coverage, especially in the last year, about the use of medications for treating opioid use disorders, in the media in particular, in part because of a lot of interest among congressmen right now and the president's Office of National Drug Control Policy in expanding access to MAT. And MAT really stands for medication-assisted treatment. Some people say medication-assisted therapy. Mm-hmm. And the idea, the nomenclature, refers to the idea that medications, pharmacological approaches, can be extremely beneficial for treating patients with substance use disorders, opioid use disorders in particular.
Okay. And for some in the field, it's a little bit of a different way of thinking about treating substance use disorders, of actually using a medication. And I was wondering if you could kind of speak to kind of how that blends into even some of the existing treatment models and the way that we provide care for patients with opioid use disorders and heroin use.
It's a great point and an important question. And often people ask me, why is it called medication-assisted treatment? We don't, you give someone a beta blocker for a cardiac indication, no one calls it medication-assisted treatment. Mm-hmm. And I think that term speaks to the historical legacy, the influence of abstinence-only approaches of 12-step models to treating patients with substance use disorders. This idea that they shouldn't be taking anything, even if they're depressed, they shouldn't be taking an SSRI like Prozac or Zoloft, that people should be completely medication, drug, substance free. What we've learned over the last 5 decades, really, if you think back to the beginning with the use of antabuse of disulfiram for treating patients with alcoholism, we've seen decades and decades now of research showing that people have better outcomes with the combination treatment of medications with intensive psychosocial and behavioral treatment, with recovery work. So the medications now, if you look at the evidence base for how to treat people, the medications are a core part of the treatment approach. We have clinical trials that look at the use of medications, but most trials, you think about millions of dollars, they go into double-blind, randomized controlled trials. they're not going to last for more than maybe 3 to 6 months. There might be a few months of follow-up, a year of follow-up, but it's very hard to have a forward-looking trial that lasts for 5 or 10 years to really get a sense of what people respond to best. So medications can be life-saving. They can help give people some protection in terms of time to build a foundation in recovery. But long-term, it often takes a lot of work after someone's been using heroin, opioids, whatever it might be, using excessive heavy amounts of drugs for years or even decades. No medication will flip a switch and make all of the consequences, the problems, the challenges that people have run into over the years go away. But medications can be life-saving to help people address the problems in their life, to regain employment, to reconnect with family, to reestablish social ties, civic engagement. It can protect their ability to do that, protect them from overdose, protect them from relapse. But ultimately, people have to put in recovery work where they won't really get into recovery.
So when you say protect, what does that mean, really, that you're protecting the person?
I think it's taken a long time, and I'm hopeful because I do think that there's been a shift in the last year in particular, going back to last spring when President Obama announced additional funding for states through SAMHSA to increase the use of evidence-based treatment with MAT. I think there's been a shift in thinking and understanding that the risks that come with addiction to opioids are different than the risks that come with addiction to alcohol or to other drugs like marijuana or cocaine. And in particular, there are two major concerns. One is overdose. So in particular, if people go into a detox without follow-up with medications, methadone, buprenorphine, naltrexone, people get detox, they lose their tolerance. And unfortunately, we know that the relapse rate is over 90% within a few months if someone's simply detoxed with no follow-up care, especially no medication-based.
So if we get someone, into a detox situation, they're actually at a higher risk when they come out of that detox.
There are concerns that detox that is not followed with evidence-based treatment is actually increasing the risk of mortality for patients. Detox, really the evidence is for detox as a tool to get people into treatment, as a bridge into a Suboxone program, onto Vivitrol, for instance, the monthly extended release version of naltrexone. But detox itself is not treatment. It can be used as a tool to get people into treatment. But on its own, if it's not followed by treatment, it actually increases the risk of overdose. That's because when people stop using opioids, they lose their tolerance to opioids. Going to detox at the end of the 5, 7, 28 days, however long the taper is, the detoxification program is, people have no tolerance at the end. And when people relapse, their tolerance to the rewarding effects of opioids increases much more quickly than their tolerance to respiratory depression, which is the mechanism that causes a fatal overdose. The brain, the switch to keep breathing is turned off if people take opioids beyond their tolerance. And so unfortunately what we're finding is people who have a 10 bag of heroin a day habit go into detox, come out, their tolerance is 0, but within a few days they're back at 10 bags. It might have taken them months or years to get up to 10 bags a day.
And that's really because, the person is really struggling to try and get the same desired effects from the heroin, but their body can't handle that level. And so they're kind of chasing that feeling, as we sometimes say, but the body kind of just can't handle that, and that switch gets flipped.
I think in some ways that's true, and there might be part of this where people are chasing that feeling, that initial high that people do talk about.
Right.
But we also know, if you look at the field of alcoholism research, that there's a kindling effect. That's what researchers call it, scientists call it. This idea that the brain, sometimes if people go into detox, that there are neural changes in the circuitry that, if anything, could cause almost like a rebound craving or a rebound escalation of drug-taking behaviors. And that's why the risk, if people go through detox without following that with long-term medication-assisted treatment, they're at a much higher risk, not just of relapse, but overdose and overdose death.
Okay. And so I know earlier you mentioned also that MAT is an evidence-based treatment, and I've heard a lot sometimes from the field that we really don't have effective treatments for substance use disorders, and I was wondering if you could speak to that.
So hands down, we have effective treatments. It depends on how you look at it, though. And the early studies often were looking at complete abstinence, as if nothing else mattered. And that's certainly a goal. But I think in part because of the influence of, a very helpful influence of harm reduction principles over the last few decades, coming out of Europe from all over the US now, we've come to understand that people's quality of life, their level of functioning, their employment can increase dramatically, can improve dramatically in successful treatments, even if there still might be intermittent or rare substance use. So now our emphasis is not just on consecutive weeks of abstinence as an outcome, but also looking at retention in treatment, looking at reductions in use, reductions in heavy use days, heavy drinking days, for instance, but also focusing on level of functioning and quality of life. When you look at patients with opioid use disorders who are on Suboxone, on methadone, on Vivitrol, the extended release form of naltrexone, we know that they are at much lower risk of death, all-cause mortality, and overdose mortality. We know that they are much more likely to regain employment, and we know that they use opioids at a lower rate. Some people still use drugs, still use opioids off and on, but we know the rates at which they use drugs are much, much lower if they're on something like methadone, on Suboxone, or on a blocker shot like Vivitrol.
And you could talk with us a little bit about some of the different MAT modalities
For treating opioid use disorders. Sure. So MAT, medication-assisted treatment, sometimes people say medication-assisted therapy, for the treatment of opioid use disorders refers to 3 different medications. Methadone, which has been around since the 60s. President Nixon funded methadone heavily when Vietnam War veterans were returning to the United States. Buprenorphine, which since 2002 has been FDA approved for the treatment of opioid use disorders, and also naltrexone and its extended release formulation, which is a monthly injection of naltrexone called Vivitrol, which is also FDA approved for the prevention of relapse in opioid use disorders. So MAT really stands for those 3 medications: methadone, buprenorphine products, and naltrexone in the extended release monthly injection. They differ in important ways, and there are pros and cons to each modality. There are advantages to methadone for some patients, there are advantages to buprenorphine for some, and there are certainly advantages to extended release naltrexone for some patients as well. But there are also drawbacks to each of these modalities, and it's not just differences in side effects or differences in induction mechanisms for getting people successfully onto the treatments. There's also some nuance in terms of how people respond to them. So, for instance, methadone in the United States is largely provided through heavily regulated clinics, federally regulated and state-regulated clinics. So there's a lot of services built into these programs, but the patients have to go every single day, 6 days a week, for months, if not years. If patients go and they're really successful in treatment in terms of not having any opioids or other drugs of abuse in their urine samples, they attend every single day without fail, then they can start to earn what are called take-homes in the field. But they only have to go every other day, maybe even once or twice a week over time. But even patients who've been in methadone programs for years, very successfully, if they miss a couple days due to a family crisis or some other disruption in their life, often they get kicked back to 6 days of attendance on a weekly basis. So imagine having a job, trying to raise kids, you have to be somewhere every single morning at 8 a.m. That really cuts in your ability to have a functioning life. So methadone's a great option for people who need that structure, and in particular early on in treatment, that amount of regulation and structure can actually be therapeutic, but obviously there are major drawbacks to that as well.
So Dr. Williams, I've heard a lot about the dangers of methadone, that it's a great risk for folks overdosing on it, and there's been a lot of talk about restricting its use, and you're talking about it as a evidence-based MAT medication. I wonder if you could kind of explain the differences there.
Very, very important point to clarify. I'm glad you asked. So if you look at overdose trends in the United States over the last few decades, disproportionately, a lot of overdoses are with long-acting or extended-release opioids. And methadone's a long-acting opioid. It works it stays in your system for 24 to 36 hours. But the pain control, the pain effect, the analgesia only lasts for about 6 to 8 hours. So unfortunately, a lot of prescribers, a lot of physicians give methadone prescriptions in pill form to patients to treat pain. And they're told to take it once a day or twice a day. But the reality is that the pain control only lasts for 6 or 8 hours. So inevitably, patients take it every 6 to 8 hours because they start to experience intensifying pain if they don't keep taking it. But the blood levels continue to climb for 24 to 36 hours. And as a result, people might take a couple extra doses of methadone on day 40, and on day 41 they actually get toxic blood levels. But they have no idea that this is happening, of course, and they overdose. So if you look at the overdose deaths that are associated with methadone, almost all of them are with a pill form of methadone that's prescribed from emergency rooms in the outpatient setting for the treatment of pain. It's not with liquid methadone, which is directly dispensed in methadone treatment programs. Remember, most people who go to methadone treatment programs are going every single morning, six days a week. They're directly observed taking their methadone in the clinic. If you look at the community, though, the patients who overdose on methadone, they're largely overdosing on pills, either their own or pills that have been shared between friends and family, which is one of the most dangerous things that people can do.
Great, thank you. Talk to us a little bit about what's different about using buprenorphine.
So buprenorphine was a breakthrough, and there's some history here in terms of treating opioid use disorders. About 100 years ago, in the 1920s or so, physicians were being incarcerated for prescribing opioids to their patients who were addicted to opium. So there's been a tension between physicians, between the practice of medicine and law enforcement officials who were concerned about the misuse of prescription medications for maintaining people, if anything, worsening their drug addictions. Our thinking has changed dramatically because of all of the evidence that's come out over the last few decades in particular. And now we have medications like methadone and Suboxone that are life-saving if people take them every day as they're prescribed. So DATA 2000 was an act that was passed around 2000 in anticipation of buprenorphine coming to market, and it did in 2002. It was FDA approved for the treatment of patients with opioid use disorders. Buprenorphine has a novel mechanism of action. It isn't what's considered a full agonist or a full activator at the opioid receptors in the brain. It's more like a partial activator. It has some properties that activate the receptor. It also has some properties that shut down the activity of the receptor. Unfortunately, the part that's blocked by buprenorphine is the part that leads to overdose, that leads to the suppression of the respiratory drive in the brain. And for that reason, buprenorphine is a Schedule III substance under the Controlled Substances Act. Because there's a ceiling effect on the risk of overdose death with buprenorphine, it's a Schedule III substance under the Controlled Substances Act. So methadone is Schedule II. Other opioids tend to be Schedule II, more or less. But buprenorphine is Schedule III, which indicates that there's less risk of abuse, less risk of danger with this medication. And because of that protection from overdose, buprenorphine, through the DATA 2000 Act, is allowed to be prescribed in an outpatient setting. So sometimes you see this term OBOT, which refers to the outpatient-based opioid treatment for patients. Because again, 100 years ago, physicians couldn't write prescriptions from their office to help patients with opioid use disorders, and now they can for the last 14 years or so because of the DATA 2000 Act and buprenorphine being FDA approved in 2002. Now the downside to this, or what some people are criticizing our current system for, is that physicians need special credentialing called an X waiver to be allowed to prescribe buprenorphine. There are still risks, and we know from early studies in France, for instance, that patients who inject buprenorphine, especially if they inject it in combination with benzodiazepines, that there can be fatalities from it. Fortunately, we don't see those trends in the United States. But because of the potential risk for harm to patients, even though it's much less than with methadone or other opioids, there are restrictions on who can prescribe it. So there's an 8-hour course that's required before physicians can prescribe it. Naltrexone has also been around for decades in various forms for different indications. For instance, it was approved in 1984, I think it was, but a couple decades ago, for the treatment of patients with alcohol use disorders. Most recently, in 2010, so just 5-6 years ago, it was FDA approved and the monthly injection form, which is currently branded as Vivitrol in the United States. The monthly injection was approved for the prevention of relapse for patients with opioid use disorders. And the idea with naltrexone is that it's a blocker. Some people confuse it, even physicians sometimes confuse it with naloxone, which is Narcan. And there's much more press, if anything, that's covered the potential role of naloxone or Narcan for reversing overdoses to try to prevent fatal overdoses. Naltrexone is very similar to naloxone, except it lasts much longer. So the pill form of naltrexone lasts for about a day, and the injection was designed to last for a month. And the idea with naltrexone, similar to naloxone for reversing overdoses, naltrexone completely blocks the activity of the opioid receptors. And what that means is that if someone has naltrexone in their system, they have that month of the active medication from the injection. Even if someone were to use heroin or take a Percocet, take oxycodone, the extended release form, the monthly injection of naltrexone will completely block the action of opioids at the opioid receptor.
So if I was on naltrexone and I took, say, Percocet, I actually wouldn't have the experience or normal feeling that I would if I was not on naltrexone?
In general, most people will say they don't feel anything at all.
Okay.
And that's part of the therapeutic benefit, is the patients who are used to paying $10 to get a certain kind of pill, to take it to get a certain kind of effect, are all of a sudden wasting their $10 and not feeling the effects they're expecting.
Am I at risk for even overdose to say, hey, I'm going to take more Percocet because I'm not feeling it?
To try to override the blockade.
Right.
So that was a big concern. And before, for any medication to be FDA approved, not only does it need to be shown to have efficacy for a given indication, but it also has to be shown to be safe. So before naltrexone was ever approved for the prevention of relapse in opioid use disorders, it had to go through safety trials. And it was not shown to increase the risk of death. And we've had studies over the last 5 years looking, several months, even several years of follow-up. And to date, there are no large studies that have suggested an increase in the risk of mortality. So there's this, what we would think of as a theoretical concern, that if someone's blocked and they try to override it by taking more and more and more Percocet, more and more heroin, something like that they would have an overdose fatality. But so far, we have no evidence to show that that's actually happening with Vivitrol. On the flip side, we know that anyone who's on Vivitrol uses opioids at drastically lower rates, which confers a lot of protection in terms of mortality risk.
So this sounds like a great medication that not only treats opiates, but also has evidence-based to treat alcohol use. Why are we not using it more?
So if you look around the country, there are thought to be about 2.5 million people who have opioid use disorders, about 500,000 addicted to heroin, and almost 2 million addicted to prescription, like pain medications, the pill forms of opioids. And maybe, it depends on which study or how you look at it, but maybe 10 to 40% of those people get treatment in a given year. And only a fraction of the patients who get treatment receive evidence-based medications, like methadone, buprenorphine, or naltrexone. So out of the 2.4 million people in the country who have an opioid use disorder, we have maybe 300,000, 400,000 people on methadone in a given year. Through the drug treatment system, the publicly funded drug treatment system, there are only about 40,000 people on buprenorphine. And the most recent data from a couple of years ago suggests that maybe 5,000, 10,000 people receive naltrexone in the monthly injection form.
I mean, that sounds severely underutilized.
So the numbers suggest in the drug treatment system that about 10% of people who need to be on MAT are receiving MAT for opioid use disorder. So the great majority of patients who would benefit from the treatment currently can't access it or get into treatment programs that disallow the use of MAT.
Do you think that most of the people that are in treatment that aren't getting it could benefit from that?
So the evidence definitely suggests that for patients with substance use disorders where opioids are the drug of choice, that MAT is the gold standard treatment in combination with psychosocial and behavioral treatment. So the idea is that because the risk of overdose death for patients who have injection histories, the risk of contracting hepatitis C, HIV/AIDS are so high that all patients should be offered MAT. And ideally, all patients would have the option of any of the three modalities because there are pros and cons to each one. And depending on the patient and depending on what phase of treatment the patient's in, one modality might be more effective than the others.
Great, thank you.
For women who become pregnant or plan to get pregnant who have opioid use disorders, the biggest risk, the concern, really would be active drug use, overdose while pregnant, or sort of withdrawal, severe withdrawal, even if it's in a detoxification program. And for that reason, the gold standard treatment for women who are pregnant for years now has been methadone, because methadone has the best results in terms of retention in treatment, reducing recreational drug use. At the same time, we've had buprenorphine for the last 14 years or so, and more studies are coming out that suggest that women who are taking buprenorphine during pregnancy actually have better outcomes. And there have been some large studies that have shown that the risk for neonatal abstinence syndrome is attenuated for fetuses or babies that are born to women who are on buprenorphine rather than methadone. So at the end of the day, either treatment that's working for a woman is what you'd want to continue, largely to prevent the possibility of relapse, overdose, withdrawal, because that's what could lead to fetal distress. And there are much lesser concerns about the potential impact of methadone or buprenorphine on the developing fetus or newborn infant. The real risk is overdose and death while pregnant.
So there are some risks, but it sounds like the risk of not staying on a medication when a woman is pregnant, it far exceeds the risk of them going off the medication.
It does. If you look at patients with opioid use disorders, the annualized mortality rate is about 1% to 2% a year, which is really concerning. If you look at the age-adjusted rate of mortality for a 20, 30-year-old woman, the risk of death is 6 to 20-fold higher if the woman has an opioid use disorder. So that's a great concern anytime, but especially for a pregnant woman. Methadone and buprenorphine help save lives. They help save pregnant women's lives. They help prevent relapse, help prevent overdose. At the same time, obviously, if there's a fetus that's exposed to methadone daily, when the infant is born, the infant will have some physical discontinuation symptoms from the methadone. It would also have discontinuation symptoms, which is called neonatal abstinence syndrome, in response to going off of buprenorphine. But an infant can't be addicted. There's no loss of control, drug cravings. It's not interfering with daily life for the infant, but there are some physical symptoms that can sometimes lead to hospitalization. The infant can benefit from having morphine administered, but we know that patients who receive much lower doses of morphine have less distress and stay in the hospital for much shorter periods when they're born to women who had been maintained on buprenorphine rather than methadone. The most important thing is to be in effective treatment.
Great, thanks so much.
So, for alcohol, yeah, none of the medications so far are that effective, and a lot more trials are needed, and there's not a lot of impetus from drug companies to spend the money to do the trials. When it comes to medication-assisted treatment, opioid use disorder is generally the place where it does the best. Goals of treatment are, of course, to treat withdrawal, reduce cravings, block euphoria from opiates, that's important to some people, improve quality of life, and keep people engaged in treatment. So I would say that treatment efficacy, or how good it is its ability to maintain people's life times its ability to retain people in treatment, multiplied by its ability to keep people taking the treatment, and then multiply that by the reduction in street drug use, withdrawal symptoms, and cravings. So at any one of these places, if you don't increase survival, or if you decrease survival, if you're unable to retain people in treatment, if people are unwilling to continue taking the treatment, and if you don't reduce street drug use, withdrawal, or cravings, you're most likely going to end up with a treatment that's a failure. So treatments that result in overdose, of course, are poor. If they're not well tolerated, their efficacy is poor. And if they don't effectively reduce street drug use, withdrawal, or cravings, their efficacy is going to be poor. So for all of these types of treatment, the effect size is good. So I would say that's either moderate or medium or large. In fact, for a lot of them, it's a large effect size. So the major issues then become compliance, and for the naltrexone shot, the long-acting buprenorphine shot, those seem to help solve the problem of compliance. And of course, heroin-assisted treatment has a relatively high rate of compliance as well. So when you have a population effect of trying to scale up compliance and multiply that times the effect size, that's what this variable ends up being. And then there's overdose risk here. Of course, with heroin-assisted treatment, there's some risk of overdose. Often with methadone, the risk of overdose is much greater at the initiation or discontinuation of treatment. And then with oral naltrexone, the risk of overdose is much greater at the end of treatment, or when you are discharged from treatment, any other time. So that leads to an overall rating of good for all three of these and heroin-assisted treatment. So that's methadone, buprenorphine, buprenorphine with naloxone, and heroin-assisted treatment, and hopefully will end up being a good overall rating for the buprenorphine, either shot or implant. So how effective are these treatments? Well, methadone maintenance, here is the outcome measure, is 50 to 80% effective when you're looking at 1 year retention in treatment and or follow-up with significant reduction or elimination, not just measuring elimination, but reduction or elimination of illicit use of opiates. So it's a fairly broad outcome measure. And then for buprenorphine naloxone combinations like Suboxone, the maintenance, you have 40 to 50% that reach this outcome. For naltrexone maintenance alone, either oral or the shot, it's pretty poor, 10 to 20%. If you try to get people drug-free without using any kind of opioid substitute and no kind of opioid blocker, you end up with really poor, 5 to 20%, probably closer to the 5%. And then if you only take them through a short-term detoxification, it doesn't matter how, you end up with the same 5 to 20% that are able to remain in treatment and have a significant reduction or elimination of legal opiate use. So this was a study published in the British Medical Journal in 2017, looking longitudinally at mortality risk for people on methadone. And it was looking specifically at the treatment after initiation and after cessation, looking for how that affected people's mortality rate. And I completely agree with the analysis. I just don't like the way they presented it, so I represented it. And here you can tell, as you get into methadone treatment, you start off with a relatively high all-cause mortality rate. And this is per 1,000 person years. So if you knock off one of those zeros, then you're at about 5.0 at about half a week into treatment with methadone. And by the time you are, well, roughly at least 3 weeks, 3.5 to 4 weeks into treatment, by the time you get there, you've knocked it down to about 0.7 I don't know if anybody can see that as a 7, but anyway. And so that's about what we had seen in that other, well, or what we'll see rather. And then if you are discharged or you come off of methadone treatment, you have a significant increase in your post-discharge mortality rate. At half a week, you're at all the way up to about 2 to 3, maybe 3 here. And by the time you reach 2 weeks, you're at about 3 or 4. I guess it's a 4. And then that's the peak of mortality after you're discharged, and then it slowly tails off by the time you're 32 weeks out, which is more than half a year. You've gone down to about this level, which is 1.5 or so, 1.4. So roughly double the level while you're on treatment. And this was looking at the difference between naltrexone shot and placebo. And you can see that placebo was not good at reducing cravings for heroin, and naltrexone was very good at reducing cravings. Here, this is placebo and return to heroin use, where you have 100% of the people here are abstaining from heroin use at the beginning, and by the end, in the placebo group, and this is after 24 weeks, you have a rate of about 40% still abstaining, so 60% have relapsed. And if you're giving them naltrexone, you've got about a 55, maybe almost 60% chance of not relapsing. And then the rate of full retention in treatment was better with something as opposed to nothing. The naltrexone kept people in treatment a little bit better than giving them placebo, which isn't to say much because the rate was pretty atrocious if you're just giving them placebo. By a little over a month, you're already down to about 62% or so retention in the placebo group, and you have a more steady decline in participation by the people in the naltrexone group. By half a year or 6 months, you're down to just less than 60%.
The brain is a complex organ at the center of our nervous system. Multiple regions of the brain are involved in the regulation of emotions, including reward and pleasure. One such region that regulates the reward pathway is the ventral tegmental area, or VTA. The VTA is stimulated by different activities, including eating, exercise, and sex. Activation of the VTA induces the release of dopamine into the nucleus accumbens. Dopamine promotes the feeling of pleasure and euphoria. One of the major neurotransmitter systems involved in modulating the dopamine reward pathway is the endogenous opioid system. The ventral tegmental area is an important part of this pathway. Within the VTA, mu-opioid receptors found on the surface of neurons are stimulated by endogenous opioids, such as beta-endorphin. Beta-endorphin binds to and activates mu-opioid receptors. This interaction induces a signal which travels along the axon, ultimately resulting in the activation of dopaminergic neurons. Here, at the dopaminergic neuron, the signal stimulates the fusion of dopamine-containing vesicles with the presynaptic membrane. This event releases dopamine into the synapse. Once released, the dopamine molecules traverse the synaptic cleft, binding to dopamine receptors found on the postsynaptic membrane. In doing so, they activate a series of neurological processes that create feelings of reward, pleasure, and euphoria. Repeated exposure of pleasure and euphoria or reward result in a learning process called reinforcement. Memories are formed that connect these episodes with their causes, which are known as conditioned associations. Like endogenous endorphins, opioid drugs such as heroin and opioid analgesics bind to the mu-opioid receptors in the ventral tegmental area. Opioid drugs, when misused, stimulate excessive release of dopamine relative to endogenous opioids, producing feelings of intense pleasure or euphoria and further drug wanting. Over time, repeated exposure to escalating doses of a full opioid agonist produces tolerance, meaning that higher and higher doses of the full agonist are required to achieve the same effect. As tolerance develops, higher quantities of opioids are required to produce the same effect previously experienced during initial opioid use. Tolerance and physical dependence makes the addicted patient susceptible to withdrawal symptoms. At this point, the patient is using opioid drugs daily to avoid the unpleasant symptoms of drug withdrawal. Partial opioid agonists are substances that also bind to mu-opioid receptors. Partial agonists stimulate the mu-opioid receptor and produce a less powerful effect than a full agonist. Because partial agonists still activate mu-opioid receptors and promote the release of dopamine, they can lead to dependence and subsequent withdrawal if discontinued. Physiological dependence on opioids results in the need to continue full or partial opioid agonists to avoid withdrawal symptoms. As opioid use continues, the brain changes over time, increasing its activation with stimulatory neurotransmitters such as norepinephrine, producing symptoms of physical dependence. Many of these changes occur within the limbic system in the brain. Next, we will turn our attention to the phenomenon of opioid withdrawal, which is a consequence of those changes. The locus coeruleus is a region of the brain involved in arousal and alarm. Many neurons in the locus coeruleus region of the brain produce norepinephrine. Norepinephrine regulates a variety of central nervous system functions, including the regulation of respiration, blood pressure, and general alertness. Imbalances in this neurotransmitter contribute to the symptoms of withdrawal when opioids are discontinued. Opioid use stimulates mu-opioid receptors, which in turn inhibit the release of norepinephrine in the locus coeruleus. To offset this inhibition, neurons within the locus coeruleus increase their activity, releasing additional norepinephrine. Upon discontinuing opioid use, stimulants such as norepinephrine are now unopposed by opioids. An excessive amount of norepinephrine in specific brain locations produces symptoms of withdrawal, including muscle cramps, anxiety, and diarrhea. Please see important safety information throughout and at the end of this video. Also, please see Vivitrol prescribing information and medication guide. Vivitrol, naltrexone for extended-release injectable suspension, is indicated for the prevention of relapse to opioid dependence following opioid detoxification. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Vivitrol is contraindicated in patients receiving opioid analgesics, patients with current physiologic opioid dependence, patients in acute opioid withdrawal, and patients who have failed the naloxone challenge test or have a positive urine screen for opioids. Vivitrol is also contraindicated in patients who have exhibited hypersensitivity to naltrexone, polylactide coglycolide, PLG, carboxymethylcellulose, or any other components of the diluent. Vivitrol with microsphere technology delivers naltrexone continuously over the approved 1-month dosing interval. Naltrexone, the active ingredient in Vivitrol, is embedded on and throughout these microspheres. The microspheres are biodegradable polymers composed of polylactide coglycolide, a complex sugar designed to gradually release naltrexone in therapeutic concentrations over a 1-month period. After administration, water absorption causes the Vivitrol microspheres to swell and slowly release small amounts of naltrexone at or near their surface. Vivitrol injections may be followed by pain, tenderness, bruising, or pruritus. However, in some cases, injection site reactions may be very severe and may require surgical intervention. Over time, the polymers degrade and break down, releasing more naltrexone over the 1-month period. The polylactide coglycolide polymer breaks down to its monomer, which is then metabolized by the body and eliminated as carbon dioxide and water. When reversal of Vivitrol blockade is required for pain management in an emergency situation in patients receiving Vivitrol, suggestions for pain management include regional analgesia or use of non-opioid analgesics. In addition, cases of hepatitis and clinically significant liver dysfunction were observed in association with Vivitrol treatment. Discontinue use of Vivitrol in the event of symptoms or signs of hepatitis. Naltrexone binds competitively with highest affinity to mu opioid receptors. By tightly binding with these receptors, naltrexone, the active ingredient in Vivitrol, produces an opioid agonist blockade for 1 month. While reversible, the blockade prevents the subjective effects of opioid drugs such as euphoria. This blockade, in combination with psychosocial therapy, is thought to contribute to the prevention of relapse to opioid dependence. Because Vivitrol blocks the effects of exogenous opioids for approximately 28 days after administration, patients are likely to have a reduced tolerance to opioids after opioid detoxification. As the blockade dissipates, use of previously tolerated doses of opioids could result in potentially life-threatening opioid intoxication. Any attempt by a patient to overcome the blockade produced by Vivitrol by taking opioids is very dangerous and may lead to fatal overdose. Patients should be told of the serious consequences of trying to overcome the opioid blockade. Vivitrol is a mu opioid receptor antagonist, which, unlike full or partial mu opioid agonists, does not stimulate brain processes that create feelings of pleasure and euphoria. Vivitrol is not addictive and does not lead to physical dependence. Because Vivitrol competes effectively at mu opioid receptors and is an opioid antagonist, it will precipitate withdrawal in opioid-using patients. Therefore, patients must be opioid-free for a minimum of 7 to 10 days before starting Vivitrol treatment to avoid precipitation of withdrawal that may be severe enough to require hospitalization. You should also monitor patients for the development of depression or suicidal thinking. Opioid dependence is a devastating disease that currently impacts 1.3 million Americans. Vivitrol is the first and only once-monthly, non-addictive, non-narcotic medication approved to prevent relapse to opioid dependence following opioid detoxification.
So once again, a reminder of what a full agonist like heroin is versus a partial agonist like buprenorphine versus an antagonist like naloxone or naltrexone. When you have no drug, your level of mu receptor activity is considered to be basically zero. If you give yourself a full agonist like heroin, you'll have a marked increase in mu receptor activity, and higher dose, the more likely you are to reach the maximum effect, which ultimately leads to becoming unconscious and respiratory suppression, thus overdose. With buprenorphine, it's much more difficult to overdose because it doesn't ever result in full activity of the mu receptors, even at high doses. And of course, naloxone or naltrexone doesn't increase activity, it blocks activity. So even if you give yourself a full agonist like heroin, well, if you have naloxone or naltrexone on board, you'll have minimal effect. So this is a year-long study looking at retention and social functioning after buprenorphine-assisted relapse prevention treatment for heroin-dependent people in Sweden, and it was a randomized placebo-controlled trial. So the placebo group received no buprenorphine and no other medications, and the number remaining in treatment, starting off with 20, which is 100%, went down rapidly, and by about 10 days you were at about 4 people. So less than a quarter of people remained, and by 50 days or 60 days they were all had left that treatment. Buprenorphine was much better at retaining people in treatment, with 15 remaining by the end of the year. And in the placebo group there were 4 deaths, and in the buprenorphine group there were no deaths. Medically assisted treatment for prescription opioids is also effective. You can see here that the number of people dependent on the prescription opioids drops off. This is at 1 year, 2 years, and 3 years of follow-up. And you've got 100% of them dependent on prescription opioids at the beginning. By the time you reach the 1.5 year point, you're at less than 20%, and then below 10% by 42 months. And the number that are abstinent completely from prescription opioids increases about 60%, and then the number that are receiving some type of opioid replacement therapy is about 30 to 40%. So, crude death rate is a measure of how many people are dying per person per year. So in 2020, the CIA has estimated that the U.S.'s crude death rate will be about 0.83 per 100 person years, and that globally the crude death rate will be about 0.77. And this is a graph from about 1950 to present, and this is the crude death rate for Americans. And you can see that it's basically on a downward trend until about 2013 or so, and then it's started to increase to 2019, I guess, when this was published. That's the most recent available information, and through the models that they have, it looks like it's going to continue to increase for at least the next 30 years till about 2050. So not great if you're a human. And this is some recent work by a group, I believe it was at Harvard, looking at mortality as compared to being in medically assisted treatment, being discharged from medically assisted treatment, and then being in an untreated group for people with opioid use disorder. So if you look at medication type for opioid substitution treatment and have buprenorphine, the crude all-cause mortality or crude death rate is 0.38, or about 0.4. If you look at all-cause mortality, any type of medically assisted treatment, it's about 0.92. It's about 1.7 after you're discharged from medically assisted treatment, and it's about 4.9 if you're untreated. So to put that in perspective, we've got here the age range for people that were in these studies that were the opioid users. They're between 20 and 45 years old, and you've got the age-adjusted death rate for the United States population in 2017, male in blue, female in pink. So overall, you've got about that 0.83 or 0.88 over here for all ages. And then for under 1 year, there's a fairly high infant mortality rate here in the United States. And then by the time you get to 1 to 4 years, it's significantly lower, almost 10 times lower. And then the minimum is between 5 and 9. And then it goes up from there. Boys through puberty, of course, becoming much more daring than their frontal lobes can control. So their mortality rate increases more dramatically than females through their 20s, and then guys' frontal lobes develop and they stop doing crazy things, and the ones that are still around do less crazy things than girls, and then by the time they're 40, they've pretty much closed the gap, and it remains roughly that way through 85 and over. So this is normal people, normies. Here's what your mortality rate is. A 30-year-old on buprenorphine treatment has a mortality rate equivalent to somebody who's 50, roughly. And any opioid substitution treatment, a 30-year-old ends up with a mortality rate similar to that of somebody who's 60 years old. if you get discharged from opioid substitution therapy, you end up with a mortality rate equivalent to somebody who's in their 70s. And finally, if you never go on opioid substitution treatment, you end up with a mortality rate equivalent to somebody who's in their 80s. And your mean age is roughly 30. So hopefully that helps to put it in perspective as to what happens when you're on opioids and you're not being treated with opioid substitution versus being treated with it. So for medically assisted treatment for nicotine use, there's three major types of medication. One is the nicotine replacement therapy, then there's buprenorphine, bupropion, or Wellbutrin, and then varenicline, which is Chantix. And this table from New York City's Health Department pretty effectively covers the suggested regimen to help people quit, the precautions to note, the contraindications to using that type of treatment, and the potential side effects of using this treatment. When it comes to how effective these treatments are, for people in these trials, they were looking at 80 different trials in this meta-analysis. They found that the abstinence rate was roughly 13% at a year, I think it is. For Chantix, there were 5 trials looking at the higher dose of Chantix, and the odds ratio was 3.1, which yielded roughly a 33, or a third of the people were still abstinent. And then you can see that, these nicotine replacements were also effective, but they were on the order of a quarter of people, which is very similar to the effectiveness of the lower dose Chantix. And then bupropion was even slightly less effective at about 24% of people remaining abstinent. And then only using the nicotine gum, which I think is the one that's easiest to get over the counter, is 19% abstinent. So minimally better than placebo, although very expensive. And so this table actually gives the effect size, and the one that I would note is Chantix versus placebo with an effect size of 2.31, which is very large effect and great. And the side effects, probably the worst one, is the super vivid dreams. And this is a curve, or a set of curves, looking at how many people are still abstinent as you increase the number of weeks after their quit date. And the red line is for Chantix, the light blue here is for Wellbutrin, nicotine replacement therapy in general in green, and then placebo in purple. So it looks like, and that this chart must be at 6 months or so. Alright, and then when it comes to medication-assisted treatment for cocaine use disorder, so far nothing has been proven effective and nothing is FDA approved for any stimulant other than nicotine, but there are some stimulant-like medications that show a lot of promise, including Wellbutrin, Adderall, modafinil, and possibly even a sustained-release formulation of methamphetamine. So basically a stimulant replacement therapy. When it comes to gambling, there have been a number of trials looking at different types of medication like opioid antagonists like naltrexone and nalmefene that have shown some positive effect. Many of the antidepressants have some type of positive effect. Mood stabilizer like carbamazepine has shown positive effect, and some of the glutamatergic drugs like memantine and N-acetylcysteine have had positive effect. But all of these trials have been relatively small. None has been sufficient to submit an application for FDA approval, and the positive effect size is not known. So in addition to helping people in the case of opioid use disorder, stay alive, and in the case of alcohol and opioid use disorder, to maintain abstinence, at least from alcohol or street drugs. Medication-assisted treatment has some other primary outcomes that are certainly beneficial. For opioid use disorder, buprenorphine and methadone treatment both reduce suicidal behavior. For accidental overdoses, naltrexone and buprenorphine both reduce the chances of having an overdose. Acomprosate for alcoholics doesn't really affect that, and methadone actually increases the number of overdoses. And then the chances of being arrested while on naltrexone, buprenorphine, or methadone all decrease. For buprenorphine and methadone, it's statistically significant. And then the rates of arrest for violent crime are decreased for all of these treatments: acomprosate for alcohol, naltrexone for alcohol and opioid use disorder, buprenorphine and methadone for opioid use disorder. The only ones that are statistically significant anyway are buprenorphine and methadone. So in summary, for opioid use disorder, the best candidate for abstinence and for survival is buprenorphine with naloxone in Suboxone right now, and that has an effect size of 1.8 for abstinence and 1.4 for survival, which are both large effects. Acomprosate is the one that has the best known effect size, which at this point is very small. So that's most likely why acomprosate is not typically given to people with alcohol use disorder. And nicotine, the CHAMP, is vareniciclline or Chantix with a very large effect size of 2.31, but one has to keep in mind that still that's only a third of smokers remaining abstinent at 6 months. For these other boxes, it's just not known yet if there are any medications that will help with abstinence or survival for stimulant or marijuana users, and the effects on survival for alcohol and nicotine either haven't been studied or I couldn't find a result. And overall, the first-line treatments for each of these are given here, and second-line treatments. So this gives a fairly decent summary of these three different types of substance use disorders and their available treatments, the FDA-approved ones, and some of the promising medications or mechanisms that are being investigated to treat these. And this is kind of a summary of all the drug effects in red, the neurotransmitter and the connections given in black, and then some of the medications that can be helpful in blocking or modifying these drug effects are also given in black. So there are medications that are effective for opioid detoxification, potentially opioid withdrawal. Of course, it's helpful to know how long or what the half-life is on the medication that the person's withdrawing from. That's given here in hours. So you can estimate when they're going to start having withdrawal symptoms. There are a number of medications that are routinely used to treat the symptoms of opioid withdrawal. For nausea and vomiting, they are dimenhydrinate and prochlorperazine. For diarrhea, it's loperamide or Imodium. For muscle pains, acetaminophen or naproxen, sometimes ibuprofen. For anxiety, dysphoria, runny eyes and runny nose, you can have hydroxyzine, which is an antihistamine. Some people have trouble sleeping. Sometimes trazodone is used to help with that, sometimes Seroquel. And then to decrease the sympathetic hyperactivity that includes a fast heart rate, elevated blood pressure, sweating, and restlessness, clonidine is quite effective. And there are medications to assist with alcohol detox. The ones that are used consistently are long-acting benzodiazepines, and this regimen here is one that is suggested. Certainly not the only way to do it. And then in addition to these recommended doses for day 1 through 5 of alcohol detox, there are also some as-needed doses. And then other medications that are used during alcohol withdrawal include anticonvulsants, if needed, and muscle relaxants like baclofen, beta blockers like atenolol, and alpha adrenergic agonists like clonidine, which can help with some of the same symptoms that you get during opiate withdrawal.
So I'm a nurse, I'm an addiction nurse, and I go into the prison system and I meet with people returning into society. So I meet with them and I do their assessments and try to help bridge their care for them when they're upon release. And I mean, the fear is real. They're so afraid. I've had them actually cry during the assessments because, you know, they have a different persona while they're in there, but inside they're full of fear and anxiety and what's going to happen when I go. It's almost like impending doom when they walk out that door. So I met with this young man. He was about 24, 25 years old. It was his first time being incarcerated. So his day of release, he came to us over at Boston Medical Center. He met with the doctor. He met with the nurse. He was started on a very low dose of medication for treatment. He's still with us today. He's engaged with care. And he meets with psychiatry as a social worker, and he has his daughter in his life, and he's grateful. I believe that a lot of the people that are incarcerated are there for behaviors that occur due to impairments. Everybody I talk to over there is typically it's because they were impaired at the time of their crime. I feel like, you know, if they had been able to get to treatment sooner, this may have stopped this incarceration and this behavior that led to their incarceration.
Criminal justice exposure is extremely common for patients with opioid use disorder. Half of the people in the federal prison system are currently serving time for a drug offense. In the 1980s, shortly after taking office, President Reagan expanded drug laws, such as mandatory minimum sentences and a 100-to-1 sentencing disparity between crack and powder cocaine. This catalyzed blatant racial disparities in the U.S. incarceration system, as well as a mass incarceration for drug offenses with an impact that has lasted for decades. Heroin possession and use is illegal in the United States. Additionally, opioid use disorder results in a compulsion to use opioids despite its negative consequences, and this often leads to what is commonly referred to as acquisitive crimes, like stealing or selling drugs. In fact, a study conducted in Baltimore, Maryland, found that over a 6-year period, people who injected drugs had a 60% risk of becoming incarcerated, as compared to people who do not inject drugs. Each year, 1 in 3 people with opioid use disorder will be arrested. And unfortunately, for many, multiple incarcerations are common. In the New York City jail system, about 40% of people with opioid use disorder reported 11 or more incarcerations. Incarceration can cause health-related harm to people with opioid use disorder. Most of these harms are related to the lack of access to evidence-based treatment while incarcerated. Specifically, these harms include 1. Untreated or undertreated opioid withdrawal, 2. Disruption of the opioid agonist treatment, methadone or buprenorphine, and 3. An increased risk of fatal overdose. The process of being arrested, arraigned, and transferred to correctional custody can take up to 72 hours, depending on a variety of factors, including the time of arrest. Because opioid withdrawal is not considered life-threatening, it is not uncommon for patients to go untreated during this time. This can be extremely uncomfortable, and it can lead to death from dehydration or suicide. It can also lead to drug use in order to stop withdrawal symptoms, increasing the risk of overdose. Despite the large number of individuals with opioid use disorder currently incarcerated in the United States, and the fact that both methadone and buprenorphine are proven to reduce the risk of death by greater than 50% in people with opioid use disorder, it is puzzling that the majority of jails and prisons do not offer these life-saving treatments. This means that if a person on methadone or buprenorphine becomes incarcerated, his or her medication is abruptly stopped and discontinued. In addition to being extremely uncomfortable, forcing people to withdraw from these medications makes them less likely to want to use the medications in the future. It also means that people who use opioids, and who may benefit from starting these life-saving medications, do not have the opportunity to do so while incarcerated. The third harm of incarceration is extremely important. Incarcerating people with opioid use disorder is associated with an increased risk of death. This risk is most pronounced during the post-release period. This is primarily driven by forced withdrawal, persistent cravings, and reduced tolerance to opioids. Exposure to opioid agonist treatment, meaning methadone or buprenorphine, is associated with a 75% reduction in death post-release. How do we reduce these harms? Primarily by ensuring timely access to opioid agonist treatment, either for medically supervised withdrawal or preferably as part of a long-term maintenance strategy if the person is interested. To reduce suffering and ensure treatment continuation, correctional settings should continue opioid agonist treatment for people already on these medications and initiate and maintain people on opioid agonist treatment inside correctional settings. Healthcare teams should prioritize linking individuals to post-release care and offer addiction treatment services inside correctional facilities.